Good afternoon, everyone. I'm not able to make it to class tonight because I do have another event. Hold on. May not be able to hear me. Okay. I do have another event tonight, so I won't be at class tonight. So what I wanted to do was go ahead and finish chapter 13. So here we go with descending tracts. There are two types of tracts in the body. And remember, when we're talking about tracts, we're talking about white matter because that's talking about columns. So descending tracts are going to carry motor signals down the brainstem and the spinal cord, because remember, the brainstem and the spinal cord are the only two organs in the central nervous system. Everything else is going to be in the peripheral nervous system. Ascending tracts are going to carry information up the body, and you're going to deal more with sensory. So one of the great things in history that we've heard about is polio, and then with recent social media craze, we heard about ALS. So let's start with polio. Both of them are going to deal with motor neurons and skeletal muscle and how they're unable to move. So the polio virus, which we don't have anymore, we don't see that because we can safely say that we have eradicated polio. What it actually does is destroy motor neurons of the brainstem and anterior horn. So when we're talking about horns, we're talking about gray matter. So it messes with the unmyelinated gray matter of the spinal cord. So people who suffer from polio end up with muscle pain, weakness, and loss of reflexes. Eventually, sometimes they have to go on to what they call an iron lung, and because their muscles, their skeletal muscles, aren't able to help them breathe anymore, so they need assistance. And then eventually, if they don't get the iron lung, then of course they go into respiratory arrest. And that is spread by fecal contamination of water. So there were poor water conditions when polio first came out. So now that those areas are treated, we don't see it anymore. Hold on, next slide. All right, ALS, that's the one we saw with the ice bucket challenge. And so everyone was dumping buckets of ice water and ice on people, and they were calling different people out to donate. The reason they were simulating dumping well, not even simulating, the reason they were dumping the ice is to simulate what the nervous system actually feels like. It's almost like your muscles and nerves are frozen and they aren't able to move. So you end up with muscle weakness, difficulty speaking, as you saw people were shivering as they were trying to call other people's name out, difficulty swallowing and using hands. But their intellectual functions and sensory stay unaffected. They stay normal and intact. It's just the motor neurons that are affected. So let's look at the spinal nerves. We have about 31 spinal nerves, and they can be broken down into what we call plexuses, and we'll go through that. So we've talked about this before. So the anatomy of a nerve, we have little rootlets at the end attached to the spinal cord, the posterior root, anterior root, the spinal nerve, blood vessels, and fascicles. Kind of looks like the muscles if we go back to looking at that. So nerves, a cord-like organ composed of numerous nerve fibers. We have some mixed nerves. Mixed nerves mean that they have sensory or afferent and motor, which is efferent. So we're going to see that throughout this chapter, going back and forth with nerves. So the different parts, so nerve fibers, we remember, are in the peripheral nervous system because the only two organs that are in the central nervous system is the brain and, of course, the spinal cord. So sensory afferent carries signals from sensoreceptors to the CNS. So if you're getting pinched, the pain that you feel will be sensory, and that's going to take it all the way to the spinal cord to determine what's going to happen. And the motor or the efferent nerve will carry the signal to the effector, whether it's a muscle or a gland, and say, hey, move your hand or move your arm out of the way so you don't continue to feel pain. So again, mixed nerves consist of both afferent and efferent. Remember, again, somatic, when usually we see the word somatic, we're definitely talking about skeletal muscle. Ganglion is another word that we're going to see, and all that is a cluster of neurosomas outside of the CNS. Remember, the soma is the cell body of the neuron. So here's our picture, again, of the spinal cord. Remember, Everything outside of that H or that butterfly is white matter, and everything inside of it is gray matter. Gray matter, again, is unmyelinated, so it's going to be a little slower, and it's going to go through, it's going to go through continuation, conduction, and then when we have the white matter, we're going to go through solitary conduction. So let's break everything down. 31 pairs, 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, 1 coccygeal. So we have cereal at 8, turkey at 12, late lunch at 5, supper at 5, and then 1 for cake. Okay, coccygeal. That's how I remember them. Now, each spinal nerve is formed from 2 roots. So if we go back up here looking at the roots, so we have an anterior root and we have a posterior root. So those are our 2 roots. So the posterior is the sensory. Of course, everything that we're sensing around us, what we feel, what we touch, what we touch, what we taste, what we hear. And then the anterior or the ventral root is the motor part. It's going to tell us, okay, we have the information. Now what are we going to do about it? So here we have the spinal nerve roots and the plexuses. So there are several different plexuses. Although we know there are 8 cervical nerves, and the cervical plexus is only C1 through C5. The brachial plexus, you can see it has C5 through C8, and it also has T1, which is a thoracic region. We come down here, we have the lumbar plexus, which is L1 through L4, and the sacral plexus, it takes on one of the L's. It takes on L4 and L5. So let's look at this again. Spiny process, we've talked about this before when we talk about the bone practical. And so here we have the posterior root. Remember, the posterior root is going to deal with sensory, and then we have the anterior root, which is going to deal with motor. This is what it looks like dissected. So you can see it looks exactly the same. You can see the little roots hanging to the side. We still have the posterior, the gracilla fasciculus. Anytime we see fasciculus, it's also white matter. So cuneate, fasciculus, white matter, columns, white matter. And then we have the dura and the arachnoid matter, which we know are the meninges, because we have pia matter, we have arachnoid matter, and then we have dura matter, with pia being the closest to the organ, whether it's the brain or the spinal cord. Then we have the arachnoid matter that looks cobwebbish. So that's where it gets the name arachnoid. And then the layer that's furthest away is the dura matter. All right, and looking at this, here's the rami of the spinal nerves. Again, we're going to have the posterior root and an anterior root. We're both going to have those too. And since we're talking about this, another disease to look at is shingles. Chickenpox is a common disease of early childhood and is caused by varicella zoster. Now, most of you all won't get it because you've already had the chickenpox vaccination. I had chickenpox as a young kid, and one of the things that we used to have is chickenpox parties so that you could catch it from one another and during the summer so you wouldn't miss school. That didn't happen in my testimony. It didn't happen. What ended up happening is I got it at school. I wanted to go outside for recess, and I realized I had this blistering bump on my hand. And I showed the teacher, and she said I had chickenpox, and I had to go home. So I was devastated. But now you all won't experience that because you have, of course, the vaccination. So it remains for life in the posterior root ganglia. So that is sensory. Remember, we talked about the posterior root ganglia. That is sensory. So it does not get activated until something agitates it. It could be hot weather. It could be spicy foods. It could be stress. Any of those things can bring it back. Now, the thought is if you have chickenpox as a young child, that you won't have shingles as you get older. Shingles we usually see with the older population, the geriatric population, and we also see it with people who have weaker immune systems. So the herpes zoster localized disease is caused by the virus. Again, it goes down to sensory neurons. It's common after age 50. You usually see it in the chest and the waist on just one side of the body. So that is shingles. Now, just to go over the plexus again, they break down into different ones. Make sure you know which goes in what, because we're going to get very, very specific with which ones you have to know. So the cervical plexus in the neck, C1 to C5. So I'm going to switch over to another one so that you can see this. Okay, this is what I need you to follow. So again, we have the four major branches: cervical, brachial, lumbar, and sacral. So this is what I need you to know from the cervical. C3, C4, and C5 keeps the diaphragm alive. So there's a phrenic nerve that originates from those three places. If any of those places it's cut, then or severed, breathing will stop. So that's why we say C3, C4, C5 keeps the breathing alive. Okay, so make sure you know that, because it's going to supply the skin and muscles of the head, neck, and the superior part of the shoulders. So please key in on knowing the phrenic nerve is C3, C4, and C5. Next is the brachial plexus, spinal nerve C5 through C8 and T1. So all of this region is going to be controlled. The region that's going to be controlled is the shoulders and the upper limbs. So let's look at a couple of these clinical applications. So we have the axillary nerve, which we know is under the arm. And what we see is it can be caused by using crutches, extreme pressure there. So what happens is the loss of deltoid function. You can't abduct. And abduct is to simply raise your arm and move it away from you. So if you were to open up your armpit, you wouldn't be able to do that. That's why they always tell you to make sure that you're balancing yourself correctly on the crutches so that you don't damage that axillary nerve. Next, we have the musculocutaneous nerve, and this is caused by heavy backpacks and extreme weightlifting. What happens is it's hard for the elbow to flex and supination of the forearm. And we know supination of the forearm is when your palm is up and you can put a cup inside of it. So it's very hard to do that. The radial nerve, this one I always talk about because a lot of students who are interested into the nursing field, if they're not careful, they can give a flu shot and damage the radial nerve. So what happens is improperly administered intramuscular injections. That means injections that are supposed to go into the muscle that are in the deltoid, it hits the nerve. Or they can put a cast on that's too tight. What happens is the wrist permanently drops and you can't extend the wrist or the fingers. So you walk around with your bent wrist because of the radial nerve injury. The good part about it, though, is because radial nerves are outside of the CNS and they're in the PNS, we can do some nerve regeneration to fix it. Now, if it was a nerve that was damaged in the central nervous system, in the brain, or the spinal cord, we wouldn't be able to do anything with it. Another injury here in the brachial plexus is the ulnar nerve. And this happens when some of us lay on the desk and we put all of the weight on our arm rather than shifting. So what happens is there's increased pressure because you're leaning on that elbow by working, and you end up with a claw hand, as you can see here. He cannot abduct or adduct those fingers. And because it's the ulnar hand, we know that this side is the side that is injured because the ulnar side is on the side of the pinky. Then we have the injury to the long thoracic nerve, and I am going to show you a video on this. It is caused by sports injuries, mastectomies, and removal of lymph nodes. So what happened is the scapula, the bone, or your shoulder bone or shoulder blade can't be abducted. So I'm going to flip over so you can see this. Open link. Let's see if it'll let me do it from here. All right, here we go with the wing scapula. This is the injury to the long thoracic nerve. Watch her shoulders and watch where the shoulder blades are, right here. And watch her rotate. Everyone see the scapula moving? You can see it kind of sitting out. So normal over here. And we can see that's not normal on this side. You can see it's still protruding out. All right. So that was the injury to the long thoracic nerve. Next, we have the lumbar plexus, the last one that we'll deal with. It has the roots of spinal nerves L1 through L4. And what happens for clinical applications that we can see on a daily basis is injury to the femoral nerve. This can be caused by a gunshot or a stab wound, and the person is unable to extend their leg. We also have another instance, injury to the obturator nerve, which is caused by pressure on the nerve by a fetal head during pregnancy. So sometimes the fetus's head is laying in that area, and it's hard for a mom to adduct that thigh. That muscle ends up being paralyzed as soon as they shift the baby, or as soon as they, of course, when they have the baby, the pain and the pressure is relieved. Okay, so that covers our plexuses. So I'm going to skip through these. All right, reflexes. Reflexes, so much fun. Reflexes are the part that allow us to see how our body works. It is a rapid and it is an involuntary response. We don't have time to think about what a reflex is or how it is performed. So the reflexes require stimulation. Reflexes are quick, they're involuntary, and they're stereotype, meaning they happen the same exact way over and over time. Some of our reflexes are learned, and some of them are we're born with them. If you think about an infant when they're first born, if you stroke the side of their cheek, then you know that they will automatically move their mouth because they were born. No one taught them when someone strikes your cheek, that means it's time to eat. Okay, so that's an inborn reflex. Now, if you've ever been driving down the street and you slam on brakes, and someone else is in the passenger seat and you extend your hand, that is a learned reflex, very learned reflex. I'm not sure what we think our hand is going to do, but that is a learned reflex. Now, more specifically for this one, we're going to talk about somatic reflexes, which involve somatic nervous system. So we're going to deal with skeletal muscles. So this I really need you all to know and key in on. This is the pathway. So we have to have a receptor first. The somatic receptor is the tattletale, muscles or tendons. We have to have the afferent nerve fibers. We have to have remember with afferent, that also means afferent and sensory, same thing. An integrating center, which is a control center so we can process the information. Efferent nerve fibers, which we also know as motor nerve fibers, and then effectors. So look at this. So here we are. If you get hit right here on the knee, there is a receptor in the muscle near the tendon that says, hey, sensory nerve, we had some pain. The sensory nerve goes up here through the dorsal root, gets right here in the spinal cord and says, hey, something happened in the leg. So then what happens is the motor or the efferent neuron takes that information back and talks to the gland or the effector and tells it what to do. Like, hey, we need to kick the leg forward. That is our reflex. Okay, so that is the reflex arc. If I could put that in order, it will be like this. Let's see. Layout. Let's do a plain layout. Layout. I think I picked the wrong one. Let me pick another one. Let's try. There we go. So reflexes. Let's be some specific somatic reflex. Excuse me for the drilling in the back. So the parts, let's label it this way. The parts of a typical somatic reflex are: you have to have a receptor that is going to be the tattletale that's going to tell you what's going on. We have to have a sensory neuron, which is also known as afferent. Ooh, misspelled sensory. Then we have an integrating center, which is our control center, which is going to tell us what we need to do. We need to have an motor neuron or an efferent neuron. And then, of course, we have to have an effector. So if we think about this like a computer, the input is the receptor and the sensory neuron. And then we're going to the hard drive, which is the integrating center. And then the motor neuron and the effector are almost like paper that you're printing out after you printed your report. So you got all the information, you saved it to the hard drive so it can process it and check for spelling, and then it gets spit out. Now what we'll see here is the difference between, well, not even the difference. We're going to see the collaboration between the muscles and the nervous system. So here are all of our muscles connected together. And we're going to talk about some stretch reflexes. One of the most famous stretch reflexes, of course, is the knee and patella. So when you hit the kneecap with the little reflex hammer, we definitely see a reaction. It's going to fight back. Very, very important in helping us to stand up straight, make sure our posture is correct, and muscles are contracted at all times to keep us balanced. So the knee jerk, like I mentioned before, by the patella, is monosynaptic. So monosynaptic reflex, there are two types of reflexes. You have monosynaptic reflex and you have polysynaptic reflex. A monosynaptic reflex only has two neurons. It has an afferent and an efferent. Polysynaptic is going to have an afferent, an integrating neuron, and it's also going to have an efferent. So it's going to have three of those areas. So let's look at the patellar tendon reflex. So we tap on it, the muscle spindle and the quadriceps femoris, the stretch signals, and then going from the foot to the afferent, because remember, afferent is sensory, so it senses some pain that happened around here and it's going to send it down. The primary afferent neuron stimulated is alpha motor neuron in the spinal cord. And then we're going to get to the motor nerve fiber, which is going to give us a knee jerk. But as I'm reading this, this probably would have occurred at least 3 times. This reflex is pretty quick. So finishing up the patellar tendon reflex, we can see how all of this is going to talk together. One going to the afferent, which we know is sensory, and then coming to the integration center, then coming all the way down here to the motor, all the way down here, back to the effector. Now the next stretch reflex is called the flexor or the withdrawal reflex. All of us have had this happen. So the flexor reflex is the quick contraction of flexor muscles resulting in the withdrawal of a limb from an injurious stimulus. What that means, if you've ever walked in the middle of the night to go to the bathroom and you've stepped on a Polly Pocket, which was the one that did me in, any kind of Lego or any kind of toy, if you stepped on something like that in the middle of the night, you instantly drew your foot up from whatever that pain stimulus was. That was a polysynaptic reflex arc, because what happened is we started with one sensory neuron, and then we went to the integration center, and from the integration center, then we went straight over into the motor neuron, or the efferent portion, and then we withdrew our foot from the injurious stimulation. So If you've experienced that, or whether it's a Lego, Polly Pocket heel, or purse, as soon as you withdraw your leg, what you notice is all of your weight goes to the other leg. And the reason it goes to the other leg is to make sure that you have balance. Otherwise, as soon as you pick your foot up, you will fall and hit your face, and that would be a total different thing. But because your body switches all the weight to the other side to give you some balance, that is called the cross extension reflex. So let's look at this. So this individual, so they step on a piece of glass at the beach, which will be absolutely horrible. And instantly, because it's cut, the sensory neuron tells them, okay, we need to withdraw that. The other neuron says, hey, flex and make this leg over here tighter so that he can stand and not fall on his face in the water. So the flexor makes you remove it, remove whatever injury site, wherever the injury site is, it wants you to remove your foot. Whereas on the cross extension is going to give you the balance so that you don't fall. We'll go over some other tendon reflexes in lab when we return back from Thanksgiving break. Spinal cord trauma, highest risk group are males 16 to 30 years old. Wonder why? I think that's because at this age, males tend to be a little more adventurous and become more risk takers. They start thinking about that dopamine, that pleasure center, and how they can continue to keep that going. So 55% of this occur in automobile or motorcycle accidents. So there's, of course, different types of spinal cord trauma. You can have a complete transection, which is a severance of the cord. That means that you're going to immediately lose any motor control below the level of injury. Above C4 means it's a threat of respiratory failure, because remember we talked about C3, C4, C5 keeps the keeps the respiratory, keeps the phrenic nerve alive, it keeps the diaphragm alive. So if we cut that area, we have a serious threat of respiratory failure. Spinal shock. Make sure you know the different types of paraplegia. So we have paralysis of both lower limbs is paraplegia. Quadriplegia is paralysis of all four limbs. Hemiplegia is paralysis on one side of the body, and paresis is partial paralysis or weakness of the limbs. Okay, this concludes chapter 13. I'm going to also put up an assignment for you all to complete for lab today in my absence. I hope that you have a wonderful and blessed holiday, and I will see you next Monday. No, there's no class this Wednesday, but I will see you next Monday on the 26th. Have a good one.